Good evening, folks. I have discussion C for you. It is now tonight's C is a speech for healthcare systems and hospitals. It talks about how to reverse diabetes naturally. Okay, so here we go for the presentation I made for you. Please enjoy. Good evening. In every hospital, every clinic, every emergency department, every long-term care facility, type 2 diabetes is part of the daily landscape. It is our workflows, dashboards, our budgets, our staffing models. It shapes our admissions, our readmissions, our pharmacy spend, our population health matrix. It is everywhere. And because it is everywhere, we have come to treat it as inevitable, but inevitability is not a clinical truth. It is a cultural one. Today I want to challenge the culture. I want to talk about reversal, the possibility of remission, the return of metabolic stability, the quiet but profound shift in a patient's life when their body begins to heal, not cure, not a miracle, but measurable, achievable remission. And I want to talk about what it means for us, not just as clinicians, but as leaders of a healthcare system responsible for the well-being of entire communities. A story to ground us. Let me begin with someone you might recognize in your own patient panels. Marie is 72. She lives alone. She gardens. She has mild frailty, osteoarthritis, and a lifetime of caregiving behind her. When she was diagnosed with type 2 diabetes, she felt what so many older adults feel: fear, resignation, and the quiet worry that her independence might slip away. But Marie began with something simple: a walk, a shift in her plate, a little more sleep, a little more movement, and her body responded. Her A1C fell, her medications decreased, her energy returned, Her identity shifted from a diabetic to in remission. Marie's story is not just rare. It is simple, under-recognized. The clinical reality. We know, we now know that a meaningful proportion of adults with type 2 diabetes can achieve remission, especially older adults, especially those with early disease, especially those supported by structured care. Reversal is not magic. It is psychologically responding to better conditions. Muscle becomes more insulin sensitive. Liver fat decreases. The pancreas resets. The pancreas sets. The metabolic storm quiets. This is not fragile science. It is evidence-based medicine. And yet our health system is not designed for remission. The systematic gap. We have built a chronic care model that assumes permanence. We have built payment structures that reward treatment, not reversal. We have built workflows that manage disease, not metabolic healing. Reversal is happening despite these systems, not because of it. That is the gap. And that is the opportunity. 3 strategic shifts for health system leaders. Reframe diabetes as potentially reversible. This begins with culture. When clinicians tell patients that diabetes is lifelong and irreversible, they are not describing psychologically and physiologically. They are describing a system that has given up. We need clinical guidance that include remission as a treatment goal, EHR templates that track remission status, quality matrix that reward A1C reduction, and medication de-escalation. This is not symptomatics. It is strategy. 2. Treat food as a converted benefit. If food is medicine, then food must be reimbursed. We need medically tailored groceries for older adults, produce prescriptions integrated into primary care, coverage for protein supplementation, to preserve muscle mass, partnerships with local growers to reduce food deserts. We cannot ask patients to reverse diabetes while giving them no access to tools required to do so. Build community infrastructure for metabolic health. Reversal does not happen in exam rooms. It happen it happens in kitchens, neighborhoods, and daily routines. We need community health workers trained in metabolic coaching, walking groups funded as public public health interventions, senior centers, strength training programs, home-based coaching for frail or homebound adults. These are not extras. They are the architecture of remission. The financial case. Let's talk about cost. Diabetes drivers, emergency department visits, hospitalizations, complications, polypharmacy, long-term care placement, workforce burnouts. Remission reduces all of these. A health system that invests in metabolic reversal is not just doing the right thing, it is doing the financially intelligent thing. Value-based contracts, shared savings models, and bundled payments for remission programs that are not theoretical. They are they are operational strategies that reduce cost while improving quality. The workforce case. Clinicians cannot deliver what they have never been taught. We need training models on metabolic reversal, nutrition and sleep psychology, integrated into CME, certification pathways for diabetes remission coaches, interdisciplinary teams that include dietitians, exercise psychologists, and behavioral health specialists. This is not fragile medicine. This is modern chronic disease care. The moral and imperative at, at its core, this is not just a clinical issue, it is a moral one. Because when we tell patients that reversal is impossible, we are not protecting them from disappointment. We are denying them agency. We are denying them hope. We are denying them the chance to reclaim their bodies, their independence, their future. Hope is not sentimental. Hope is strategic. Hope is catalytic. The vision forward. Imagine a healthcare system where remission is expected, where older adults are supported, not scolded, where food is covered, movement is coached, and metabolic healing is a shared goal, where stories like Marie's are not exceptions. They are the norm. This is not a dream. It is a direction, and it is within reach. Let us build a system that believes in the possibility of reversal. Let us build a system that honors the biology of healing. Let us build a system where type 2 diabetes is not a life sentence, but a condition that can be quieted, softened, and yes, reversed. Thank you. Okay, guys, that is C for you. I will be back on with D shortly. Give me a bit for a small break, please.